Good afternoon, good morning, everyone, and welcome to the Adam Alliance Quality Innovation Network Learning and Action Network Telehealth Series Session 2. It's entitled Making the Right Call on Telemedicine. We've got speaker A. Yarnell Beatty from Tennessee Medical Association. My name is Jennifer Ride, and I'm with the Adam Alliance, and I'm going to be your event moderator today. Take a minute to go over our agenda. We've got a few housekeeping items we're going to cover. We'll then have some opening remarks by Wanda McKnight from THIMA. We also are going to have Mr. Yarnell Beatty from Tennessee Medical Association present. We'll have time for questions and answers and also some closing remarks. As you may know, Adam Alliance is a 5-year, 5-state initiative to ignite powerful and sustainable change in healthcare quality. We welcome participants from Alabama, Indiana, Kentucky, Mississippi, and Tennessee, as well as other states that may be participating. We appreciate all you do to improve quality and achieve better outcomes in health and healthcare, and at lower cost for the patients in the communities that we serve. The objectives for today's webinar, after today you're going to be able to see if telehealth is a good fit, know the regulatory and legal aspects and the requirements to practice telehealth. Find out some common barriers that we've seen to telehealth and delivery for providers, and look and discover what trends you might see within the telehealth industry. There are some housekeeping items that I'd like to go over. So first of all the phone lines have been muted so that we have better sound quality during the presentation. We encourage your participation, though, throughout the event through the chat participation. You can select to send your question or comments to all the participants or just certain individuals from the drop-down menu as you see here on the slide. A few of us from the Adam Alliance are going to be monitoring the chat box for questions and any feedback that you'd like to share, and we'll either respond in the chat box during the call or respond directly to you. So a link to download the slides from this presentation will also be posted in the chat box for your convenience. Another thing we're going to be doing is if you want to ask panelists questions directly or privately, you can use the Q&A function to direct your question to certain individuals. Also during today's presentation, we're going to be using some polling questions. So we're aiming for 100% participation in some of these polling questions. So please don't be afraid to answer. All of your answers are anonymous. These questions are going to come right up on the side of your screen, and they're going to be part of the WebEx polling feature area. Right after you've selected your final answer, please be sure to hit the submit button so we can capture your answer. At this time, I'd like to introduce you to Wanda McKnight. Wanda is a board member for the Adam Alliance and for QSource. She's also a fixture here in the Tennessee healthcare community. She's the executive director of Tennessee Health Information Management Association.
Thanks, Jennifer.
Wanda.
On behalf of the Tennessee Health Information Management Association, I want to express my gratitude to QSource and the Adam Alliance for allowing us to be a part of this important project. THIMA is very devoted to quality health care through quality information, and we are happy to be partnering with our friends at QSource and other organizations to explore and promote discussion about health information exchange, telehealth, and other advances to improve the health of Tennesseans and everyone in the Adam Alliance and across the country. So it's my pleasure now to introduce our speaker for the day.
Thank you so much, Wanda. I appreciate that. And welcome to Making the Right Call on Telemedicine. I'd like to start out by thanking all the folks, host organizations, Adam Alliance, QSource, THIMA, everyone for putting this series together and for inviting me to present today. They're all friends, and I appreciate their hosting today. They've been very supportive. My colleagues would have a big chuckle if they knew I was presenting on a topic even remotely related to technology. Folks, I am the least common denominator when it comes to using and understanding technology. Technology just doesn't like me. But here's a quick list of what I plan to go over today. This presentation is geared to the novice or the practice that's exploring the possibility of utilizing telehealth. And I've divided the presentation into 5 modules. In Module 1, I'm going to define telehealth for you and give you an overview of its capabilities. You don't know what it can do, how can you make an informed decision whether to use it? In Module 2, I'm going to address licensure requirements that a doctor has to have in order to utilize telemedicine. Module 3 will have us look at state and federal regulations as to how telehealth is delivered in Tennessee. Questions such as what conditions have to exist for an encounter to be considered telemedicine? What if the technology used is inadequate for your provider to make a diagnosis? What do you do? Can you prescribe? In Module 4, we'll look at whether and how your provider will be reimbursed for telemedicine. What good's investing in all that technology if you won't get paid? How do you bill and code for telemedicine? Module 5 is going to help you decide whether telemedicine is right for your practice. We look at barriers to telehealth delivery. I'm going to predict some future trends in Tennessee and provide you with some resources to help you incorporate telemedicine in your practice if that's what you choose to do. I'll then take some questions from the audience, so if you would please reserve your questions for the end. Many will be answered during my presentation. What I will not get into is specific questions about technology. As I have previously stated, I am a technologically challenged lawyer, so please consult your vendors for that kind of consultation.
So, we'll have a polling question here. And the first question is, what is the status of telehealth at your organization? And they're going to pull that, WebEx will pull up that polling. There we go. And so choose A, not planning to participate in telehealth. B, in the beginning stages of planning for telehealth services. C, we have been providing telehealth services for less than a year. Or D, we've been providing telehealth services for more than a year. Don't forget to hit submit. And again, that's A, not planning to participate. B, in the beginning stages. C, for less than 1 year. Or D, for more than 1 year. And there we go. It looks like a little bit of a mix here, but I'd say the majority are, there are 2 here, now that have for less than a year. And then there are some that are in the beginning stages. Thank you. Back to you, Yarnell.
Very good. That's about what I predicted. I figure a lot of people are probably in the exploratory stage, so it looks like that's where we are. So let's go on to Module 1, which is an overview of telehealth. What is it and what it is not, and it gives you a basic understanding of the capabilities of telehealth. To help better understand what is meant by telemedicine, it's best to start with what is not considered telemedicine. Under Tennessee law, telehealth and telemedicine do not include an audio-only conversation, a telephone call, not telemedicine. Email, not telemedicine. Fax, not telemedicine. There are really 2 definitions of telemedicine under Tennessee law. One's in the licensure section of the state code, professional health licensure section. One's in the state insurance code, and that one addresses when health plans have to cover and pay for telehealth services. Both of these definitions are very similar. They contain the same basic elements that I've listed listed on this slide. We're going to dig deeper into each of these elements in this module when we talk about the capabilities of telemedicine. The first question I answer is, what is the physician-patient relationship created under the concept of telemedicine? And there are really three concepts that will paint this picture for you. It isn't much different than when a physician-patient relationship is created in an in-person situation. First of all, one of two things has to happen. Either a doctor affirmatively undertakes to diagnose and treat the patient, or the doctor is brought in for consultation. That's the threshold. Second, unless there is an emergency, the patient has to know that the doctor is participating in their care. Obviously, if the patient's having a stroke and unable to consent, his consent is implied when the healthcare provider is treating or advising on the care for the stroke via telemedicine. A physician-patient relationship does exist because it's an emergency. And as an aside, treating strokes via telemedicine is very, very common these days. Third, say you're conversing with an out-of-state doctor who is providing you some information about possible patient referral. No patient relationship. It's not a consultation. You're just considering whether to take the patient on. So in that instance, no physician-patient relationship exists. What does the law say about standard of care on telemedicine's use? Bottom line, the statute creates parity in the standard of care between telemedicine and the provision of the same service in person. This is important. If your physician is a dermatologist, let's say, and is trying to diagnose a rash via telemedicine, she's held to the same standard of care as if the patient was in the room with the doctor. The doctor doesn't get any liability slack because she can't touch the rash, or if the color on it on the screen might be skewed by the technology, there's still the same level of risk. Let's get into the capabilities of telemedicine. There's really three broad categories describing the capability of telemedicine. The first one is called store and forward. And the best way to explain it is by example. Imaging illustrates this very well. Let's say you have a technologist, an X-ray technologist in a rural West Tennessee hospital. Technologist takes an X-ray of an injured patient at 10 o'clock at night. There's no radiologist at the hospital. For after-hours X-ray interpretation, the hospital has a contract with a radiology staffing company in California. The Tennessee X-ray technician loads the image and sends it electronically to a secure portal in California. A radiologist in the pool of radiologists available in California logs in and views the X-ray. 30 minutes later, an interpretation is dictated by the radiologist who has the X-ray report sent electronically back to the hospital in Tennessee. So the image was stored in Tennessee and forwarded electronically, forwarded to California, where it was read, interpreted, and a report was generated and then sent back to Tennessee. So you have store and forward technology. There's never any doctor-to-patient or doctor-to-doctor direct interaction. So differentiate that scenario from real time. So we'll go to interactive, the second category. This is your traditional virtual visit. Think Skype, only with better technology. An example would be a psych evaluation over telehealth, where the provider and the patient have a discussion back and forth. So interactive is the second capability. The third is monitoring. Sleep tests combine both store and forward and monitoring. The sleep technologist can monitor the patient on a screen in real time and remotely can capture those vital signs and readings and then store them for review by the sleep medicine doctor at a later time. Another question I often get is whether there's a difference between the terms telemedicine and telehealth. You hear both. Whether it is telemedicine or telehealth merely depends on who's providing the healthcare service to the patient. If it's being performed by a medical doctor, osteopathic physician, or a physician assistant, the service is telemedicine. If it is being performed by some other type of healthcare professional, it's telehealth. That's it. But we're going to use those terms interchangeably for purposes of this presentation. So that concludes Module 1, and we're going to go on to Module 2 right now, which is going to deal with the licensure requirements. So our goals are to know when a Tennessee medical license is required in order to provide telemedicine services and which state license a physician has to have in order to deliver telemedicine. If the patients you're going to treat via telemedicine is located in Tennessee, then the rule is that the treating physician must have a Tennessee license unless there is an exception that applies. There are two types of Tennessee licenses available. You either have to have a full Tennessee license or a Tennessee telemedicine license in order to practice telemedicine. Tennessee telemedicine licenses are only issued to out-of-state doctors, and they're extremely limited in scope. In fact, beginning next October 31st of 2018, the Board of Medical Examiners in Tennessee is no longer going to be issuing telemedicine licenses. So physicians who currently have a telemedicine license will have some options. They can transfer the telemedicine license to a full medical license, or they can keep the telemedicine license. So let's talk about the telemedicine license. There are really only a few certain physicians that would want to retain a telemedicine license, and those would be if, first of all, the physician has to maintain a current ABMS specialty certification. The physician has to limit the telemedicine practice to, quote, the provision of medical interpretation services in his or her area of special board certification, and the doctor cannot prescribe, not at all. So unless an out-of-state provider is a radiologist, pathologist, or someone else who just practices medical interpretive services, the out-of-state provider needs to have a full Tennessee license. And again, that transition has to be done by next October. There are some exceptions where no license is required at all. You're probably familiar with most of them. If there's a second opinion requested by a Tennessee physician and there's no payment for the second opinion, that can be delivered by telemedicine without a license if the patient's in Tennessee. If there's a U.S. military physician who's practicing within, say, a VA hospital, there's no licensure requirement. If the information is just used to determine if the patient is covered by insurance, again, no license. There are other exceptions in the law, but those are the main ones.
Okay, and we've got another phone question. And this one is asking, what type of services is your organization providing? And these are telehealth services. And A is none. B is you've got a pediatric specialty. C, neurology, or D, behavioral health. And don't forget to hit submit. And again, choose A, none. B, pediatric specialty. C, neurology, or D, behavioral health. And we'll give just a little bit of time for that to compute. Okay, I don't see any of the, all right, are we still waiting for that to compute?
We've got a couple people in.
Okay, there we go. And it looks, it looks like C, neurology, and then maybe some behavioral health, and then other. So I'd say neurology is the leading answer there. Darnell?
Very interesting, and I would have thought that behavioral health would have had a higher percentage. I think that's a growing area, certainly in rural areas where there are access challenges. So, very interesting. So let's press on to the third module, which is delivery of telemedicine in Tennessee. So here, our goal is to provide an overview of the regulatory requirements to practice telemedicine in Tennessee. This particular module is limited in scope to telemedicine by physicians. And the reason that is because I'm going to go over the rules that the Board of Medical Examiners has come out with for physicians that were effective in October of 2016. There are several regulatory conditions on telemedicine, and they depend on whether a facilitator is present. A facilitator is someone who's with the patient when the patient is being seen via telemedicine. A facilitator is required to be present when a patient is 18 or is under 18 years of age, except as otherwise authorized by law. And as otherwise authorized by law, that would include situations where the minor patient can lawfully consent to treatment. For example, an emancipated minor. An emancipated minor in the state of Tennessee is someone who's at least 16 years of age, married, and they can consent to treatment without parental consent. So if a facilitator is not present, what has to happen? Well, number one, the patient has to utilize adequately sophisticated technology to enable the physician to verify the patient's identity and location with an appropriate level of confidence. Number two, the patient must transmit all relevant health information at least the level of store and forward technology or secure video conferencing. Again, we talked about interactive versus store and forward. And third, the physician has to comply with the state title identification law, which many of you are well familiar with. The provider providing the service has to disclose what type of provider they are. Are they a doctor, nurse, practitioner, and what their recognized specialty is. That's done with either a name tag or a sign in the office. So the same applies to telemedicine as well. If a facilitator is present with the patient, the facilitator must personally verify the identity of the patient and be able to transmit all the relevant information about the patient, again, using either store or forward technology or have that interactive conversation. The facilitator has to identify himself to not only the patient, but also the remote physician who's practicing via telemedicine. And the physician, again, whether the facilitator is present or not, still has to comply with the title identification law. Tell who they are. What kind of medical records and documentation is required for a telemedicine encounter? Frankly, it's just not that much different than an in-person visit. A physician has to have the appropriate patient medical records or be able to obtain information during the telemedicine encounter to be able to adequately treat the patient, same as in person. All the pertinent data and information from the telemedicine counter has to be documented in the patient's records. Again, you would do that during a face-to-face visit. And be cognizant of the fact that the rules require that the technology used must be entered into the medical record. I don't know what that means. I don't know how specific that has to be. But I think that at a minimum, the physician would need to document that it was an interactive telemedicine encounter, something to indicate that it was a telemedicine visit. I don't think they have to go into the brand of technology used or so forth. The extent to which a physician can prescribe using telemedicine, I'm sorry, I got ahead of myself. Anytime technology is used, things can go wrong and cause the examining physician not to be able to make a diagnosis. So what has to happen if that's the case? Say that the transmission is just not of good quality, something goes wrong, then the physician is required by the rules to declare that he or she cannot form an opinion to make the diagnosis. So they've got to tell the patient, what's wrong and why they can't make a diagnosis. They also have to tell the patient that they need to either directly refer the patient for an actual physical examination, request additional information, recommend that the patient be seen by their primary care or someone local in their area. And I want to mention also that the rules are silent as to whether a physician can charge the patient if the physician has to declare that the diagnosis cannot be made. Presumably they can, because at least some evaluation is being conducted, but that's not directly addressed in the rules. The extent to which a physician can prescribe depends on the type of license the physician has. If the physician just has the telemedicine license, prescribing is not allowed at all. Doesn't matter if it's legend drugs, scheduled drugs, control, whatever. They can't do it at all. If the physician has a full license, and that's what we really are talking about, prescribing is allowed, but there are some limitations. And again, most of the limitations are identical to the limitations that apply to an in-person visit. You have to perform an appropriate history and physical examination. You have to make the diagnosis based on all the diagnostic and appropriate lab tests that are required. Third, you've got to formulate and discuss the therapeutic plan with the patient. There's got to be informed consent. You've got to go over the risks and benefits of the various treatment options. And number four, you've got to ensure the availability of the physician for appropriate follow-up care, whether it's a physician who is practicing via telemedicine or someone in the patient's area, but they have to have follow-up care or someone available for follow-up care. A prescriber cannot prescribe a drug based solely on answers to a set of questions posted online. This was a huge problem when telemedicine started. The technology really outpaced the regulations. So you had these online questionnaires you could go on, answer a few questions about pain or something, and then get mail order opioids. Bad idea, but certainly has been banned by the Board of Medical Examiners and at federal level as well. Prescribing controlled substances is governed by the state chronic pain guidelines, which do not allow chronic pain to be treated via telemedicine. So I interpret this to mean refills as well. The rule of thumb here is if it's a chronic pain patient, seen in person. Must an in-person encounter take place before a physician can prescribe controlled substances via telemedicine? Well, being the typical lawyer, the answer is it depends. An in-person encounter is not absolutely required to take place in order for a prescriber, a physician or a prescriber to issue controlled substances via telemedicine. There might be instances in which an in-person physical examination should be performed. Certain medical conditions may necessitate in-person encounters. The Board of Medical Examiners rules provides a list of exceptions where a physician absolutely can prescribe without doing a history and physical. And some of those are you issue admission orders for a prescription for a newly hospitalized patient, for a patient you're taking call for, short-term medications for a new patient prior to the first appointment, for established patients where the physician just doesn't feel that there needs to be a physical examination, for the treatment of chlamydia, that's specifically carved out in the law. Controlled substances can be prescribed, that they're governed by federal law at 21 U.S.C.A. 829. And remember, again, this is non-chronic pain prescribing of controlled substances only, acute only. Federal law allows what's called a covering practitioner to issue a prescription by telemedicine without doing any history or physical. And under federal law, that a covering practitioner is merely someone who's conducting a medical evaluation using telemedicine at the request of another doctor, another practitioner, who's conducted an in-person evaluation at least within the last 24 months and is unavailable. So if you're a covering practitioner, you would not necessarily have to have a in-person visit before that. Note, please, that the federal law disallows partial fills of Schedule II controlled substances by a practitioner engaged in telemedicine. Continuing on with the discussion of can a physician prescribe controlled substances via telemedicine, TMA believes that the Federal Controlled Substance Act carves telemedicine out of a broader usage of the term electronically. So if a prescriber intends to prescribe controlled substances based on that set of questions on the internet that I talked about, then such an encounter would require the in-person visit, the history and physical before it takes place. Otherwise, and to reiterate this important distinction, the Board of Medical Examiners rule requires that a physician, before prescribing or dispensing any drug by any means, telemedicine, whatever, has to perform an appropriate history and physical examination. Now, that can be in person or it can be via telemedicine. You know, there may be adequate examinations you can do by telemedicine. You may be able to get at the diagnosis by asking questions of the patient. So the treating physician is the one that makes that determination. It really boils down to standards of care. There's no hard and fast rule, but take prescribing for acute pain. It's hard enough to evaluate pain in an in-person visit, but evaluating it over electronic means can be really tough. That may be an instance where you need to have it in person. On the other hand, if you're dealing with a patient, psychiatry patient, where the interaction can be through questions, through how the patient feels. Typically, those examinations are the patient's not touched by the doctor, so that may be, telemedicine may be perfectly appropriate without any prior in-person visit. Going on to Module 4, this is where we're going to talk about the elements that are necessary for a health provider to be reimbursed from a health insurance company or Medicare for a telemedicine visit. This is where I think telemedicine gets a little trickier than normal.
Okay, and now,
Go ahead.
I'm sorry. And now we'll go ahead and have our third and final polling question, and that is, what are the major concerns that your organization has regarding telehealth? A, getting paid for telehealth services. B, technology functioning correctly. C, patient privacy, security, compliance concerns. Or D, documentation in the medical records. Don't forget to hit submit. And again, that's what are your major concerns regarding telehealth? A, getting paid for services. B, technology functioning correctly. C, patient privacy and security compliance concerns. Or D, documentation in the medical records. It might be hard to pick just one, but we'll see what we get. Don't forget to hit submit. Okay, there we go. And it looks like A, getting paid for telehealth services is the greatest concern, followed by documentation issues. So there you go. Burnell?
Yes, that is a legitimate concern, as I'm about to get into now. That's an excellent segue to talking about reimbursement, because it is very confusing. Tennessee law, we're going to talk right now about a particular provision, TCA 56-7-1002, which is located in the state insurance code. And this statute addresses telehealth in terms of how it's treated by the health insurance industry. As I've stated before, it defines telehealth. This law is what we call a parity law. And the intent is to make telemedicine coverage by health plans on par with coverage of the same service delivered in person. So telemedicine is subject to terms that are set out in your network provider agreement and the health plan's payment policy, just like any other reimbursement for service. The law does make several requirements of the health insurance entity itself. I want to go over some of what the health plan is subject to. As I read the statute, there's a requirement to make telehealth covered under the patient's health care policy. This is separate from requiring payment for it or from dictating how much a plan is required to pay. A health plan cannot have coverage requirements for reimbursement policies for telehealth services that vary with the qualified site location. I'm going to get into that, where the patient's located, such as the physician's office versus a hospital versus a school clinic, wherever the patient's located. I don't think that it means that the health insurance is required to reimburse for telehealth services at whatever geographic location that the patient happens to be. So, what are the Tennessee state law requirements placed on health insurance companies as far as reimbursement is concerned? First, a health insurance company cannot exclude a service from coverage solely because it is provided through telehealth instead of in person. Next, a health insurance company is required to reimburse healthcare service providers who are out of network for telehealth under the same reimbursement policies applicable to out-of-network healthcare service providers, so if it's in person. And health insurance companies are not required to pay total reimbursement for a telehealth encounter, including including the use of the telehealth equipment. So they could pay more for telehealth, but they don't have to. So they could pay the same as an in-person service. So you would not be able to charge an add-on for to kind of go toward payment for the technology. That would not be permitted. In order for telemedicine services to qualify for reimbursement under Tennessee law, the encounter has to meet requirements as to where the patient is located and where the treating provider is located. So both have to align. Both requirements have to be met. This slide lists the qualified sites where the healthcare provider must be located in order to qualify for reimbursement. In other words, if the teledoc is not at one of these particularly listed locations, then there's not going to be reimbursement, not eligible for reimbursement. But as I said, it also has to align with where the patient is located. And the slide I have up now lists where the patient has to be located in order for the provider to be eligible for reimbursement. You can read it. I'm not going to go over it. But I need to point out that noticeably absent from this list is the patient's home, which you would think would be where, that would be where it would be a very desirable place to want to initiate an encounter. You've got a sick child, and to be able to call in and be able to have that interaction over the internet would be very desirable. However, since home is not on the list of qualified sites, there's not insurance reimbursement for that. So consequently, what you have is that if the patient's at home, and some of those businesses that treat patients at home are cash-only businesses right now. It's our understanding that there's a new modifier for telehealth services rendered to patients who are under commercial health plans. Modifier 95 can be appended to E&M codes 99201 to 99205 for new patients, and 99211 to 99215 for established patients. You've got a modifier GT for Medicare, and that is services delivered via interactive video and video telecommunications systems. Bottom line, you need to check each insurer's reimbursement rules and policies for the services that are covered and the applicable billing procedures. You need to clarify with each of the health plans what modifier to use, 95, GT, and whether the list of codes is the same as Medicare's or if they have a broader coverage. We've been talking about Tennessee commercial health insurance reimbursement. Now I want to shift to Medicare. This is governed by the Medicare conditions for payment. The first condition is that the service delivered by telehealth has to be on Medicare's list. You need to check online for the Medicare's list of covered services. Some of the additional conditions, there's a technology requirement. A telehealth service has to be furnished via an interactive telecommunications system to be eligible for Medicare reimbursement. It has to be an eligible service. There's a list of codes that you need to check. That would include things like office visits, office psychiatry services, and I will say again that the list of codes is evaluated each year by the Secretary of Health and Human Services, so there are some changes. Typically, there are additions to the list, so this is something that needs to be reviewed every year. A telepresenter at the original site is not required. think that would be similar to what I talked about earlier in the Tennessee law, the facilitator. So a facilitator is not required in order to be reimbursed. And like Tennessee use of the term qualifying site, Medicare pays for telemedicine services provided only at what they call an originating site. And that means only specifically listed sites at which the patient is located are eligible. And there are some site requirements too, and it's very narrow. It has to be in an area that is designated as a rural health professional shortage area. It can be in a county that is not included in a metropolitan statistics area, or from an entity that participates in a federal telemedicine demonstration project, and you would certainly know if you were part of that. So again, it's very narrow. I think that eventually this is going to broaden to kind of expand beyond the rural realm, but that's in the future. The eligible originating sites are your typical ones: physician office, hospital, federally qualified health center, skilled nursing facility. There's a long list of qualifying sites under the Tennessee, under the Medicare conditions. If all conditions are met, then the provider and the facility are paid by Medicare for the telemedicine service. CMS pays us the facility fee to the originating site, and that's reported as a HitPix Q3014. There's also a professional fee, and it's based on the E&M, and again, that has to be, you have to append that with the GT modifier for Medicare. Medicare payments to a physician for telemedicine has to be in an amount that's equal to if it had been delivered in person. So Medicare has parity as well. So we're heading down the home stretch. We're now in Module 5, which is a wrap-up. And I'm going to start by kind of going over some of the barriers to telehealth delivery. Now, I know a lot of you have said that your practice is exploring taking the plunge into telemedicine, and you need to know, if we do that, what are some of the barriers we might encounter? Well, there's an uncertain national health care climate. Is the ACA going to be repealed? If so, what's there? Is medical technology companies, do they still want to make the investment in improved teletechnology with all this uncertainty? Is it going to be covered? Is it going to be incentivized? So we're really taking a pause on the national level. Reimbursement, I've talked a lot about the barriers there. We talked about qualified sites, the originating site under federal law. So there are limitations as to where the provider and or the patient has to be. There are legal barriers. For instance, there's a lawsuit in the state of Texas where a Teladoc, a major telemedicine company nationwide, has filed an antitrust lawsuit against the Texas Medical Board. The Texas Medical Board had come up with rules prohibiting prescribing without a prerequisite of a face-to-face encounter. Well, that damages Teladoc's model, which is no in-person requirement before the telemedicine encounter. The Federal Trade Commission has sided with Teladoc against the board. I think that lawsuit is going to be settled pretty soon, and it's my understanding that the medical board in Texas is going to back off with its requirement of a face-to-face encounter before prescribing. I was unable to find any Tennessee malpractice cases, so I think that professional liability coverage is going to be evolve. Most telemedicine is covered now under existing policies, but if there are subsequent lawsuits, if there are liability payments, will liability risk be forced into riders in the future? Will they say, yes, we'll cover an in-person visit, but if you're going to branch out in telemedicine, it's going to cost you more based on a rider. That hasn't happened yet, but that's something that you have to think about in the future. There's heightened protection if you're engaged in psychiatry. Behavioral health records, there's that heightened scrutiny over protecting those records. Business associate agreements, if you're going to have a vendor with your technology, those have to be in place. If you're really technologically savvy and venture into mobile health apps, then those, if that's a platform for a diagnosis or treatment, those are regulated by the Federal Trade Commission. Well, there's some additional federal regulations. If the apps are used for prescribing, maybe the FDA weighs in. Wireless networks, that's regulated by the Federal Communications Commission. And if fraud and abuse might occur, if you have a telemedicine claim that's falsely filed. So as you see, it's not as clear-cut as just a license and you can go. There are many other regulatory legal barriers that you have to be aware of. Competition from out-of-state providers. I hear that a lot. There's no longer is your competition the clinic across the street, even in the same town or even in the state. Now, does telemedicine make competition nationwide or even worldwide? Continuity of care. If you're going to have a patient seen through telemedicine on an acute basis, are the results of that going to be reported to the primary care physician, so that they're aware of that treatment? You've got privacy and security, the hacking concerns, and then again, states like Tennessee, we border 8 different states, so if you're going to enter into telemedicine and see patients out of state, you've got to comply with each of the other states. So a lot to consider in terms of barriers. They can certainly be overcome. Some future trends. Telemedicine will grow because both consumers, employers that offer health care, they're demanding it. So I'm looking into my crystal ball, what do I see for telemedicine for Tennessee? I think for one thing, there's going to be more emphasis placed on it by lawmakers. In the Tennessee General Assembly, there's a perception that there are pockets of shortage of healthcare providers, especially in the rural areas. And I think our regulators will look at that and see telemedicine might be a solution to be able to provide services in their areas. It most certainly will ramp up the use in schools and by employers. In the last 2 General Assemblies, there have been amendments to the telemedicine statute to add different types of schools to the originating site. So that's going to grow. In the legal arena, I think that there will be gaps that will be addressed. Expansion of the qualified site requirement, things like that will be addressed. And hopefully there will be faster clarification of the technology that can be used, especially with respect to what delivery modalities are secure. Is Skype, some of these things that are commonly used, are there adequate security barriers in place to make sure that it's safe? Technology is only going to get better, so there has to be nimbleness and regulation. My take-home concept is just kind of a punch list of things to keep in mind. What telemedicine is not. The rule of thumb to be licensed where the patient you're treating is located. Understanding that qualified and originating sites in both state and federal law in order to be reimbursed for services and know when you're going to be reimbursed. Under state law, the roles of facilitators facilitators and what the facilitator or the doctor and patient are responsible for. I'll spend a lot of time on the preconditions for prescribing and being able to understand that, the Medicare conditions for payment, and the bottom line of the fact that a patient's home is not a qualified site, so there's no insurance reimbursement for that, cash only. And at the end, I put together just a couple of slides of resources for you, and I'll direct your attention to the Board of Medical Examiner FAQs, which is the first one listed on this slide. If you have questions about telemedicine, it might be a good idea to submit the question to the Board of Medical Examiners, and maybe they can answer it online. And then the PMA's guide, law guide, we have over 200 topics, and we're adding telemedicine in the next few days to that. So everything that's in these slides and much more will be included in our online guide. So I encourage you, if you're providers or TMA members, to check that resource out soon. AMA is always an excellent source, I think, for resources for anything. If you're providers of AMA, the steps forward helps you prepare the steps you have to take to do telemedicine in your practice. This slide has my particular contact information on it. If you have any questions that come up later on, you'd like to contact me, I'd be more than happy to respond. Just tell me you're on this presentation, and I will get back to you as soon as possible. So that's it. I will now take questions, and
So now we had a question come in via the chat that asked, is there a sense of how the regulatory conditions in the state have impacted the adoption rate of telehealth in Tennessee?
Yes, I think that adoption has been slow because legislation and regulation has been very slow to come. It took the Board of Medical Examiners almost 2 years to come up with their rules addressing telemedicine. And I think a lot of providers were looking at that and waiting to see, what are these rules going to look like, and, am I going to be able to afford to adopt? So there's been, again, some amendments in the last few years, but when you look at the history of all this, except for the telemedicine license, which has been around for a long time, other regulation and kind of the parameters around it are very new. And again, the Board of Medical Examiners rules were only effective in October of 2016, not even a year. So I think now that we have a little bit of a lay of the land of the regulatory scheme, practices will be able to sit down, look at those, and be able to see if telemedicine is the right way to go for their practice.
Okay, fantastic. I've got another one here that says, do you think that eventually a home could be considered as an approved site if a home health nurse with their therapist is present and the patient has an interactive visit with the physician?
Short answer, yes. And I would say that that might be the steps that the regulators take. Start off by covering it if there's a facilitator present. So you have an elderly patient who has a caregiver, someone like that who could be a facilitator. I think that insurance companies, Medicare, regulators, I think everyone might have a better taste about telemedicine in those situations. So you might see that progression where it might be covered or require coverage for certain services if a facilitator is present before they just go full on. If the patient's at the home, will pay.
Okay, we just had another one add. that says, could you speak a little bit to the difference in telemedicine for chronic care versus other conditions?
Yeah, for chronic care, I would say that one of the benefits of telemedicine is the behavioral health realm. And I think because it provides, one, access, and two, there's a lot of flexibility there in terms of when encounters can take place. You know, if there's an emergency, or if you have a patient that needs to be virtually seen, then telemedicine is so much easier than saying, all right, well, I'll see you Monday morning in my office. So I think for that, there's a lot of nimbleness in that area.
Okay, great. And on that one, I mean, you're getting quite a few questions here. What can a patient, practice, or concerned citizen do to help advance telehealth in their state?
The most important thing you can do is contact your state legislator. I mean, again, the coverage. I think a lot of people are really very concerned about insurance coverage for telemedicine, because that's going to be the emphasis for its growth, and it's just going to be a matter of a grassroots effort. I think what we'll see in the coming years is more pressure put on employers, on insurance companies, to cover more services via telemedicine, because it's quicker access. There are a lot of services that can be provided that really don't need an in-person encounter. So the rank and file should just write a letter to their legislator whenever, or urge them to enact legislation to expand the capabilities of telemedicine and the coverage for it, insurance coverage for it.
Great. And just a follow-up a minute ago from the asking about the difference between telemedicine for chronic care versus other conditions. They said, meaning could chronic care in the future be considered for home as originating site without the presence of a healthcare provider?
Yes, I think within the realm of possibility, and as technology improves, I see that happening. Yes.
Okay, at this time I don't see any further questions in the chat box. Oh, sorry, I do see another one's come in here. It says, is there a specific distance that the patient has to be outside of the servicing area for reimbursement?
No, not to my knowledge. The law simply says that the patient and the treating provider not be, quote unquote, in the same location. And there's no interpretive guideline or rule that further explains what that is. So that's the best the law does. It doesn't address whether the service can be on the same campus of a hospital, for instance, or there really is no distance guidance that I've been able to find.
And one more says, is there a sense of how the regulatory conditions in the state have impacted the adoption rate of telehealth in Tennessee?
I don't have any early indicators, but I can only think that now that everything has settled down with the rules and providers are able to review the Board of Medical Examiners rules, know what the parameters are, that it's only going to grow. And I think a lot of providers were waiting for those rules to be promulgated just to see how they were going to be. And I will say that when they were originally proposed, the original set of rules was very restrictive. For instance, the board did require an in-person visit for before a controlled drug could be prescribed and before prescription. So, they were very restricted to begin with, and after hearings and after comments, the board kind of backed off of its very narrow and restrictive parameters, and I think kind of has taken a middle ground where it's not just the Wild West show out there. There are some oversight on telemedicine, but I suspect that here we are less than a year into it. I think we're going to see if this poll that we've looked at with our participants today. I would not be surprised if it didn't double in terms of those who are either planning to use it or are already using it.
Okay, we've got one more. It says, the same documentation requirements for coding apply with telehealth, for example, level 2 or level 3 visits?
I'm afraid I don't know the answer to that question. I can follow up and see, and then, or if the person asking the question wants to email me directly with that, I'll be happy to follow up.
Okay, and does the parity law cover the patient seen in non-rural areas for private payers?
It would under state law, under federal, under Medicare conditions of payment. It would not at this point.
Okay, I don't see any further questions in the chat log at this time.
Sure. Now, this is Jennifer. If you want to advance the slides to the next slide, there's a question that I see here about being unable to download the PowerPoint slides due to their firewall. So you can also go to the on-demand learning area of the adamalliance.org, and you may be able to download them from that area. There's going to be also a way that you can go to, let me see, I'm sorry. Yeah, it's going to have a list of the opportunity. It tells you the requirements to participate, submit your name and other information, and you'll have you'll be able to download any of the on-demand learning sessions of your choice if you go through that process. So hopefully you can get those. If you can't get them, please contact us, and we'll be able to just email you the slides if you can't get them from the on-demand learning session. Thank you so much, everybody, for joining us. A big thank you, Yarnell, Beatty. Thank you so much for your all of your information. I know that's a lot to absorb in one setting, but thank you for putting that together so we all have a better understanding of the legalities and healthcare arena of what we need to be anticipating. Thank you also to the participants for joining the call today and participating in the polls. We really appreciate that. Please know that the Adam Alliance staff, we're here to help you. That's what we're here for. So please contact us if you have any questions, regarding what you've just heard, or if you need some technical assistance or, some help with your improvement activities. The call was recorded today. A transcript is going to be posted to the Adam Alliance website, where I've mentioned before on the on-demand learning. So be sure to check out all of our past presentations in this one as well. And I do want to ask you to please complete the survey. If you go to the next slide, I think it's on the last slide, there's a survey question. Please be sure to provide your feedback to us. We would love to have you like us, tweet us, send information about us, connect with us, pin us, however you would like to get the word out about what you've learned today. We really appreciate that. And again, thank you for your participation. Everyone have a great afternoon.